Proposed Hamstring Tightness, a review of the literature by Misty Chastain. First, I'd like to start off with an outline. I will have an introduction, and then I will go into the anatomy of the hamstring area, and then talk about ways to measure range of motion, a couple different ways, some current treatments that we are all familiar with, and then some new treatments that we are now familiar with due to this summer, and then a short conclusion to my topic. First, the introduction. Complaints of hamstrings are an ongoing issue in today's clinical setting, as we all deal with on a daily basis. Patients without injury are coming in constantly complaining of tightness, or decreased flexibility, decreased range of motion. Because of these complaints, injuries can often occur and patients miss out on activities such as practices or games. But what is actually the problem? Do they have short muscle fibers? Do they have a decrease in flexibility? Do they have a musculoskeletal issue such as lumbar spine, thoracic spine, maybe a knee or an ankle issue, or any other types of issues that may come from this? Stretching programs, which I will talk about later, have been the go-to source of hamstring tightness, but they seem to have short-term flexibility effects. People coming in daily, and my goal is to eliminate their daily visits to the clinic. The reviews that I've done, these stretching techniques and their effects on flexibility, but why aren't they giving long-lasting results in patients with complaints of hamstring tightness or decreased range of motion? So let's start off with anatomy of the hamstring. Hopefully you're all familiar with this anatomy, so this will not even be a review for you. It influences multiple joints, such as the pelvis and the joints of the lower extremity. There are 4 muscles of the hamstring. The first muscle running on the lateral side is the biceps femoris, which consists of the long head and the short head. The long head, biceps femoris, originates on the lateral ischial tuberosity and sacrotuberous ligament, and then attaches at the head of the fibula. The short head originates at the lateral intermuscular septum and the distal third of the lateral femoral cortex. The 2 medial muscles are the semitendinosus and the semimembranosus, and these originate on the ischial tuberosity and run to the posterior medial tibia. Because of this multiple attachments of the muscles, it allows functional impact throughout the pelvis and the lower extremities. And not only does a hamstring provide flexion and extension of the knee, but it also affects pelvic tilt and rotation, and also provides hip extension. The hamstring also allows for sacral rotation and also hip rotation as well. Now on to taking measurements of hamstring flexibility. Historically, most people tend to use the straight leg raise. This is challenged due to the movement of the pelvis, because the origin of the hamstring is no longer fixed. Also, it's challenged because you can receive pain from nerve root irritation. This is due to the stretching of the sciatic nerve. Small straight leg measurements mean that they have decreased hamstring flexibility, and large straight leg measurements mean they have increased hamstring flexibility. Traditionally, range of motion is measured with a goniometer, although inclinometers can be used as well, and I will talk about that here in the next slide or two. Goniometers are varying in size and can measure up to 180 degrees to 360 degrees. Placement is very important for taking measurements regardless of what joint you are going to be measuring. The pivot point needs to be lined up with the greater trochanter when measuring hamstring range of motion. The stationary arm is lined up with the midline of the pelvis, and then the movement arm is lined up with the long axis of the femur using the lateral epicondyle of the knee. Patient keeps their knee extended, and then they are asked to bring their leg off of the table or flex their hip. This can be done passively or actively. As this is being done, the movement arm travels with the leg until the end point is reached. Another way of taking measurements for the hamstring, which eliminates pelvis rotation and nerve stretching, which I have been using in the clinic and have been finding great results, is the active knee extension. The patient lays supine, the hip and knee are brought into 90 degrees of flexion, and then the knee is actively extended until limitation. You can also do a passive measurement, but I have been using the active knee extension instead of a passive movement. This is what the active knee extension looks like. It's ideal to place some sort of barrier on the posterior part of the leg so that they stay at that 90-90, and then I place the inclinometer on the tibial shaft to show their range of motion. Active knee extension can be measured with the goniometer or the inclinometer, which I talked about earlier. If you are using the inclinometer, which I have downloaded on my phone, it's placed on the anterior lower leg at the tibial tuberosity, and then they are asked to actively extend their knee. If you're using the goniometer, the stationary arm will be in line with the femur, and the movement arm will be in line with the lateral malleolus. And then the knee is extended and a measurement is taken. According to Kindle et al. In 1993, normal straight leg raise range of motion is anything greater than 80 degrees, and according to Lee et al. In 96 and Gajosic et al. In 92, a normal straight leg raise would be anything greater than 70 degrees. So as you can see, there are conflicting information on what would be considered normal for a straight leg raise. I did not find any information on what would be normal for the active knee extension. There are several different current treatments that I'm sure that we all use in our clinic, and we're probably using these on a daily basis. The first one is stretching, whether that be static, dynamic, ballistic, proprioceptive neuromuscular facilitation, or PNF. These stretching techniques tend to be relevant for sports that include plyometric activity, which is pretty much any sport that we have. They are also shown to enhance performance and assist in the rehabilitation process. Other treatments that we tend to use are ice, heat, diathermy, and also electrical stimulation. For static stretching, this takes the hamstring to the end range and it is held. It tends to be easier and more practical for the patient to perform this technique by themselves, but there are better techniques that would require, but they require the use of a clinician, and we will talk about those here in just a couple minutes. Static stretching tends to increase flexibility. It is found in these articles between 7.5 degrees and 12.5 degrees with an active knee extension testing after 30 seconds worth of treatment. In another article that Bandy and Irion did in 1994, there was significant increase in range of motion from a 15-second stretch to a 30-second stretch, but there was no significant difference from a 30-second stretch to a 60-second stretch. So it was shown that 30 seconds would probably be about the norm for holding this static stretching. Proprioceptive neuromuscular facilitation, or PNF. The first technique is hold relax. This is used when the agonist muscle is too weak, and is also you take and you lengthen the muscle to a point of limitation, and then the patient performs isometric contraction for up to 10 seconds. This is followed by a passive movement of the involved muscle to the new limitation. And again, the PNF stretching techniques do have clinician involvement in them, but they are considered to be better than the static stretching techniques. The contract-relax method of PNF stretching is similar to the hold-relax, passively placed into a stretch position, and then an isometric contraction of the restricted muscle. And then after contraction period, patient is told to relax the contracted muscle and activate the antagonist muscle to move into greater position of stretch. So this is where it tends to be different than the hold relax. And then through reciprocal inhibition, the tight muscle is then to be relaxed. Is proprioceptive neuromuscular facilitation superior to static stretching? There tends to be conflicting information. According to O'Hora et al. In 2011, they did say that PNF provides a significant increase in immediate hamstring flexibility compared to static stretching, but compared to Faison, Mulligan, and these other folks, they said that PNF does not provide a significant increase in flexibility. So I guess maybe that's another study that someone can do as well. On to modalities. The first one that I think we all use is heat. Draper in 2002 found that there is no difference in groups that were using stretching only, diathermy and stretching, and a control group. I found this to be quite interesting because we have patients come in every day using heat to warm up their hamstrings, and then they are getting stretched. But it is shown that there is no difference between those folks that are heating and stretching or just stretching only. Also, Henriksen et al. Found that there was no difference in groups using stretch only and a hot pack and stretching as well to increase their flexibility of their hamstrings. Increase in short-term flexibility in ice and stretch group versus heat and stretch group. It was found that the ice and stretch group did in fact increase short-term flexibility. This was very interesting to me because to me ice does not tend to loosen up any muscles. So and then in all of these articles, stretching alone on a daily basis does in fact increase flexibility, which we all know that as well. There was one article done on massage, and it stated that using PNF stretching, they did not say which technique they use, contract, relax, or hold, relax, but it did show that PNF stretching showed significant increase in range of motion when they compared to groups that either had just a massage or a general type of warm-up, such as a bike or swimming or any type of warm-up that you may have your patients going through before heading out to the field. These are some new treatments that we talked about this summer that I will be using in my research. The Selective Functional Movement Assessment, or the SFMA, we are all familiar with now, and in the cookbook it states that the SFMA is used to acquire patterns of function and posture for comparison against a baseline. It also ranks the quality of the functional movement, may provoke symptoms if they are having any pain, demonstrates limitations, and also demonstrates dysfunctions, and the SFMA maps movements at a functional level. The SFMA is done by a top-tier assessment which has 7 categories of functional movement, including cervical, upper extremity, multi-segmental flexion, extension, and rotation, and also single leg stance and overhead deep squatting. Some of these categories have more than one test, so there is a pattern. There are 10 patterns total. There are 4 options for patients to describe their pain. It's either they're not going to describe if it's functional or non-functional, functional or dysfunctional. That is up to the clinician. But we have functional and non-painful. This is where they performed the pattern functionally and the patient reports no pain. Or there's functional painful. This is where they performed the pattern functionally, but there was pain. There's dysfunctional non-painful, where the patient performs the pattern dysfunctionally or not correct, and there's no pain. And then dysfunctional painful, where they perform the pattern dysfunctionally and with pain. After you finish these patterns, when you start going through the top tier, if you want to do a breakout with one of these assessments, you want to start with the dysfunctional non-painful and or the functional painful. So, but if there are a lot of them that are dysfunctional non-painful, so if multiple movements classified as DN, a hierarchy must be considered. So for example, the cervical is the very first one in the top tier. If it is listed as dysfunctional non-painful, it needs to be addressed before the forward bending being listed as dysfunctional non-painful, because the forward bending is several steps down from the cervical assessment. The Mulligan concept, or the Mulligan traction straight leg raise, is what I've been using so far in my action research, and it has been having awesome results, which hopefully I will have some of those to report to you later on. It's said to improve mobility of tight hamstrings and also can improve mobility in patients with leg pain of the lumbar origin. So some of you guys that are doing lumbar issues may want to try out this concept as well. And there's limited research for the Mulligan traction straight leg raise, but in the research that I did find, it has been increasing hamstring flexibility an average of 15.6 degrees. And this is much better than the static stretching technique that I talked about earlier, which ranged from 7.5 to 12.5 degrees. So on average, it's getting about 3 degrees more of flexibility. And the straight leg raise, the traction straight leg raise the numbers continue to increase post-intervention, which this is indicative of long-lasting stretching effects. This article was written by Hall et al. In 2001, and I am actually finding this to be true because I've been having patients come in a week or two after providing Mulligan, and their numbers are actually increasing even though I have not touched them in a week or two. Another treatment that we spoke about this summer, which I have been using in my action research as well, if I am finding patients to be stuck while performing the Mulligan technique, I tend to do positional release therapy on them and then try Mulligan again. Positional release therapy, according to the book that we received this summer, is an indirect technique that places the body into a position of greatest comfort and employs tender points to identify and monitor the lesion. You place the involved area or muscle in an ideal position of comfort, and then the tender point will reduce irritability and normalize the tissues. So my conclusion is stretching, whether that be the static or the PNF, tend to be the go-to techniques, but there is no research to show if it has long-lasting effects. And it requires multiple applications. Patients have to come in daily. And most of the research was showing it was over a 4 to 6 week application period. So my question is, will this Mulligan traction straight leg raise provide these long-lasting effects? I hope that you found this information helpful, and hopefully I will be getting some good results and we can clear out our clinics from all the hamstring tightness patients that we tend to get on a daily basis. And here are my references for your use.